Good afternoon, everybody. I hope Dr. Shan and Dr. Asad are with us. We'll start with updates first, small updates. We have, I'll just show you. Please write in the chat if you can't hear me or if you have any question or comment. We'll get to them later. So this is the agenda of today. I'll give a small updates. Then we'll start with Dr. Shan and Dr. Asad utilizing CUSP tools, learning from defects. Then objective outcome measures will be with my colleague, Mr. Abdullah Al Zahrani. So this is this here just to show you how we started from the last 5 weeks. And now we're in week 7 and how it's progressing. I see if we hide those who did not start yet, that there is the green is becoming more. There is a slight progress, if you can see from here compared to here. There is a slight progress, and this is a good indicator. So we hope to everybody to keep moving on and try to enter data as much as possible in the few coming days. So we'll go with Dr. Asad. Are you ready? Can you
Sure. Good morning.
Good morning.
Good afternoon. Can you hear me?
Yes, yes, I can hear you.
Fantastic.
Yeah. I'll just put your slides on.
So thank everyone for coming on today. And we are going to be talking about, actually, Mom, I have a new set of slides that I had shared. If you want, I can
Yes,
I can share my screen, or what is better?
Whichever you want. Do you want me to change the control to you?
Sure, because I did share a new set of slides with you earlier as well.
Okay, I have done that.
Alrighty. Can you guys see my screen, or?
Okay, 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 Dr. Asad. Just, I think this is the one. Got it. Can you see the screen? Is this the one you're?
Yes, please.
Okay. This is the new one.
Yes, please.
Okay. Sorry for that. Please go ahead. This is the new one. You still can move the slide.
So you have the control. Okay, thank you. So thank you, everyone, and sorry for the delay. We're going to be talking about some of the tools that we've discussed about as part of the CUSP program, and a very important tool that we've always found to be very useful going forward, which is the learning from defects tool. So the goal of this talk is really to understand how to address whenever an issue happens or mistake happens, and we're going to get into the definition of defects, how to address it in a systematic manner, which in our opinion should involve the ability to answer 4 questions about any issue that arises. What happened? Why did it happen? What you will do to reduce its risk? And how will you know in an objective manner that it worked? To help you do this and fulfill these objectives, we're going to be talking about a specific tool, which is the learning from defects tool. So we all know that healthcare is a dangerous experience, and the data out there shows that about 4% of patients in hospitals experience some sort of adverse events. ICUs, where we all work and where NASAM is taking place, is a particularly high risk area because of the fact that ICU patients are more critically ill, have many more things and interventions that are occurring to them. So the potential for mistakes is significantly more than regular hospital patients. Some studies show that risk of suffering serious adverse events is as high as 17%, which means in the US healthcare system, at least almost 100,000 errors happening every single day, of which a quarter are potentially life-threatening. Before we move any further, we do need to realize what we mean by a defect. The simplest way for me to think about this is if something happens that we do not want to happen again. In the context of this project with NASAM, it's if something happens regarding the ventilated patient that puts them at risk for a ventilator-associated pneumonia or ventilator-associated event, or we are unable to adhere to the best practices for ventilator-associated events. The converse of this can also be true when something happens that is not supposed to happen. There's different ways to approach addressing these issues when they arise, and I'm sure many of you are familiar with this. The first way, as medical providers, all of us are solution-oriented and are very used to dealing with many things that are unpredictable happening, and then also making sure that the patient gets what they need. I know there's different approaches to addressing these sort of defects. One way to organize thinking is to think about first order and second order approaches. So with first order problem solving, we talk about how we are able to solve the problem for that one patient, but doesn't actually reduce the risk for future patients. And this is something that I have been guilty of many a time, right? When the medication for a patient hasn't arrived yet, we'll make do. We'll find the medication from another source, from our triage bag, or from often from our code card, to be able to provide for that patient in that moment and make sure that they do not suffer from the lack of that, from that defect of not having medication. However, that doesn't necessarily help future patients and doesn't solve the problem. Second order problem solving is when we reduce the risk not only for our patient, but also for future patients by improving work processes. And this is the sort of concept that we encourage you, and I know many of you were there at the NASAM launch workshop when we talked about patient safety and the science of safety. So this is the type of solution and system level approach that we want you to think about, right? If the patient isn't getting medication on time, why is that happening? Where is the delay happening within the system? Is it the pharmacy? Is it the delivery? And how can I help reduce that delay or fix that problem so that this helps not only my patient, but also future ones? There's many ways to assess defects. One of the ways that we encourage, especially in the context of our project for NASAM and reducing ventilator-associated events, is a frontline provider safety assessment. It's also called the staff safety assessment, or the 2-question survey, which really asks providers within your unit proactively to think about how the next patient in your clinical area will get a ventilator-associated event or not get the best practices that are recommended under the VA bundles. We'll actually be hopefully spending some time in another session talking about this specific tool. There's other tools that vary by hospitals and locations, and depending on resources, some of you might be familiar with them or have them already in place, like adverse event reporting systems, sentinel event reports, which look at important issues that might have happened, or mortality, for example, complications, infection rates, morbidity and mortality conference, or claims data, and if you collect that sort of information. So there's many ways that you can assess defects. I found that one of the most powerful, and Dr. Berenholtz will probably mention this also later on, that we advocate for is a frontline provider safety assessment, which we'll talk about on another date. What do you do once you find out why things aren't happening the way it's supposed to, or find out that there's trouble in providing the patient with the best evidence. So these are the 4 questions I mentioned earlier. We need to know what happened, why did it happen, what can we do to reduce the chance of recur, and what do you know that, how will you know that the risk was reduced from happening again? So what happened really is simple. And we're all familiar with, having worked in the medical profession. And it involves reconstructing the timeline and explaining what happened. The twist often ends up being in trying to place yourself in the shoes of those involved in the middle of the event as it was unfolding. And this can be something that takes a little bit of practice. I know I've often been guilty of assuming that I knew what happened, why it happened, and because of my preconceived biases. And that's often led me to a solution that didn't really address the core solution. We need to try and understand what the people were thinking, the reasoning behind it, and try and view the world as they did while the event was happening. Because things can often look very different at 2 a.m. as opposed to rounds at 9 a.m. When we think about why it happened, we also need to think about it from a system perspective. And I know we've talked about this before when we talked about the science of safety, about how do we look at the system lens, in terms of what led to that event. Often the result is because of things extraneous to the actual issue, and we're going to get into some examples of that. The damaging consequences might not be evident while the triggering event happens. If you recall, we talked about the case of a patient, of a resident pulling out a central line in the middle of the night and causing a air embolus in the patient, causing them to code. We had a similar issue with somebody doing a bronchoscopy in a patient who was intubated because of a pneumonia. Things were getting worse, wanted to make sure, obtain cultures, but it was late at night. The fellow was on by themselves who was qualified to do bronchoscopy and get cultures, so decided to do it, a directed culture that way. But when they went to get the cart wasn't fully stocked. It was urgent, there are other things pending, and they ended up using the bronch cart as is. Turns out that the adapter that keeps the air in was missing, so the patient wasn't able to maintain PEEP for the duration of the bronchoscope. The fellow thought they'd be able to do it very quickly. However, visualization was a little bit difficult because of all the secretions, and it took a little bit longer than they were thinking. The loss of PEEP ended up being detrimental to the patient and became hypoxic. They hadn't turned the pulse ox tone on the monitor, and didn't notice that the SAT had dropped during one of their passes. And ultimately, the patient ended up having a hypoxic arrest. It's easy to think that it was all the fellow's fault. Why did they do the procedure in the first place? So they didn't know if they took too long, they weren't practiced enough. But they were, when you reviewed it from a system point of view, they were basically set up by the side because previous person used it, hadn't called the number on the card to have the cleaning people come back and get it cleaned and restock the card. The nurse who was there assisting them and the respiratory therapist who was there assisting them do the bronchoscopy knew that the PEEP was going to be affected by the lack of their piece, but didn't feel empowered enough to speak up and stop the fellow. So all these things end up being an issue, and the why often ends up being very difficult to ascertain in terms of just one specific causative factor. When we review the list of factors, and when you think about such incidents, it's easy to think about those that negatively contribute, and that's often our norm. What we also need to think about are what are positively contributing factors and how they might have limited the impact of harm, because ultimately it's a balance between the two. And what we want to do is maximize the positive contributing factors and minimize the negative contributing factors. Here's the case example we were talking about earlier. And this is the example I was giving about the system failure. And I know many of you have seen this Swiss cheese model about all the things lining up just exactly. They were all errors or defects that people knew about and were aware of beforehand. It was only in that specific situation where things lined up perfectly to allow the patient to suffer and get hypoxic arrest. I know many of you have probably seen this diagram also about how system factors really impact patient safety. I like to think about it as an onion. So how a system has many levels where problems may occur, and these system factors are really nested. I know there's no real taxonomy. We prefer to place the patient in the center just because the patient is the center and the focus of everything that we're doing. And in this case, we're trying to minimize the risk of getting ventilator-associated events or harm from the ventilator. But there are things around it that end up being issues that can minimize the impact of the intervention that you're doing, which might be task-related, individual provider-related, related to the team and the teamwork, the work environment, or even the hospital institution. The next step really is to try and figure out what we will do to reduce the risk. And this is the third question that we want you to ask. And this really comes down to utilizing principles of safe design to design your intervention. We need to standardize what we do to eliminate the chance for defects, create independent checks and balances, as well as make the whole process visible and transparent so that others know what is going on, when it's going on. And these safe design principles apply not just to technical work, but also to teamwork. When we're thinking of solutions, it's easy, and I know I've been guilty of this in the past also, to think about, well, we'll create a new paradigm and educate people because obviously it was an issue of them not knowing what to do at that point. Turns out that many engineers have created a rank order for error reduction strategies. And many of the things that we often end up doing, like creating education modules, educating staff, creating new rules and policies, end up being at the lower end of, and trying harder, end up being at the lower end of the rank of error reduction strategies. You ultimately want to develop stronger error reduction strategies. Things like checklists end up being a little bit stronger than rules, policies, standardization and protocols, automation, computerization, enforcing function constraints. An example of this is something that we were recently subject to as part of our new electronic medical record system, which used to require us, whenever we're putting in medication orders, to enter the patient's initials from their first name and some letters from their last name before accepting the order, which forced people to really check the patient's name and associate the name with the order you're putting in. And such forced functions dramatically reduced the incidence of wrong patients for the wrong medications for the wrong patients. When you design interventions, as we know, this is a different way of looking at the similar sort of concept about how some actions are weaker than others. And a lot of warnings, labels, passive interventions end up being weaker, and the strong interventions really end up being things such as architectural changes, forced functions, minimizing steps, standardizing equipment. And one thing that you'll notice over here is actually tangible involvement and action by leadership and support of what you're doing. And this is one of the steps, as you might remember from last week, that the CUSP program really is built around, which is having senior executive leadership being involved and participating in your CUSP teams. The next question that we all should be able to answer is, how do we know that errors were reduced? And this ends up being a very important question because when you look back weeks, months, or even years later, you need to be able to measure and quantify what you did and how much it improved things. It could be simple in terms of having process measures? Did you create a policy process? And do the staff know about it and how many people took it? But ideally, you want it to be stronger and more outcome oriented, like we're doing for NASAM, as Eman mentioned earlier, putting in your data so you can get your results and tracking that over time. And the outcomes that you're measuring in terms of length of stay, in terms of infection rates, are much stronger indicators of how how the intervention that you're doing are reducing the risk to the patient. Ultimately, we need to summarize and share findings from any defects that we find and shared within your organization. Far more important than that is sharing with your staff and the people who are actually doing the interventions to provide the outcome improvement that you're looking for. There's various ways that you can share these sort of improvements or plans. Here's one example based on some work that we did at Hopkins, which basically ends up creating a one-pager identifying the issue, the failures, as well as opportunities for improvement and what was done to prevent harm in this case. I'm sure many of you have your own tools and are able to use them. For the next few slides, I just wanted to quickly show a visual of the hard copy of the Learning from Defects tool that the Armstrong Institute has developed, which basically asks those 4 questions, and we'd be happy to share with you. And I'm sure the NASAM team can upload it, if they haven't already, to their website for your use. But basically, a paper version of what the principle we were talking about earlier about what happened, why did it happen, and trying to look at it from contributing factors, both negatively and positively. We put them in various buckets such as patients, task-related, caregiver-related, team-related, training education-related, technology-related, your local environment-related, and your institutional environment, and how all those things contribute. There's also a publication on its utilization that was published in the Joint Commission Journal, and we'll try and make sure to share that with you or provide access to that along with the tool. The tool then asks you to summarize contributing factors, the top 5 of them, positive and negative. This is the next question we talked about. How will you reduce the likelihood of this defect happening again, and what are the interventions you'll take? Ranking them out and helping you decide amongst them with a simple scoring paradigm. And then the final question of how will you know that risk is reduced in the long run? This is a simple slide and a summary of the previous CUSP for MVP project, which Dr. Berenholtz led across the US, and which served as the pilot for the NASAM team, and how it utilizes CUSP and these principles of learning from defects right in the center, with the interventions that you're doing to minimize spinal-associated harm around it. And just for your familiarity, I know many of you are familiar with them, these were the daily care process measures that we used, and I believe many are using even as part of NASAM, such as subglottic endotracheal tubes for patients who are intubated for more than 3 days, head of bed elevation, minimizing sedations, doing daily spontaneous awakening trials, and utilizing a validated sedation scale, doing daily spontaneous breathing trials, as well as assessments of delirium. And these were the interventions that we did as part of the CUSP MVP project in terms of daily early mobility interventions. So I know we want to spend the next half fielding questions and allowing the NASAM team to present a few more things, but the key lessons that I want to leave you with are that whenever we're looking for solutions to the problems that we face, defects in how we are doing with our NASAM bundle, we really want to focus on systems, not people. We want to this can be done utilizing the Learning from Defects tool or other tools that you might already have in place. But the key is to prioritize not just the defects, but also interventions. When you're designing interventions and solutions, use safe design principles. It's better to go fix single problems very well rather than try and fix all of them at the same time. So go a mile deep and an inch wide rather than a mile wide and an inch deep. And with that, I'm gonna pause right here. I think Dr. Berenholtz has anything to say. Maybe you can share a few words and we'll hand it back to the NASAM team.
Dr. Latif, thanks so much. Can you hear me?
Yes, sir.
Great. So that's a great introduction. I want to just frame this out a little bit more, just to kind of reiterate some of the things that you kind of emphasized. So, you know, I think that as we've talked about in the past, right, perhaps the most important principle of patient safety over the past decade is the idea that when mistakes happen within our organization, it's not the result of a nurse or a doctor, but it's the result of how we've organized our healthcare delivery system, right? So for this project, if you come across a patient in ICU who has not received the evidence-based therapies they should for that we've been focusing on in NASAM, so whether, you know, patients don't have a subglottic suctioning endotracheal tube when they should, patients did not get their sedation turned off in the morning the way that they should, patients did not get the spontaneous breathing trial, or their head of bed isn't elevated. Oftentimes we focus on individual providers, right? That nurse isn't reading the protocol, that doctor doesn't know the evidence, and he's not providing good care. And that's oftentimes how we tend to focus our efforts, right? We educate that nurse at the bedside when we walk around and we find that they haven't stopped sedation. Why haven't you done that? You know that as part of this project, you know, we require every patient to have their sedation stopped, or, you know, focusing on respiratory therapy. Why aren't you doing what you should? Why aren't you turning down the ventilator to deliver low tidal volume ventilation? And we can continue to do that, but the reality is that, again, this isn't about individual providers. It's not about your respiratory therapist, your doctors, and your nurses, but it's really about how your ICU is set up, right? Because if it wasn't that nurse that didn't do what they should, the same is going to be a problem with another nurse. So what we need to do is to develop these system level lenses to really understand how it is that we organize our delivery system and organize the care in our ICU to really ensure that patients get the therapies they should. And it shouldn't matter if it's that nurse or if it's that respiratory therapist or it's that doctor or this doctor. Patients should always receive the evidence-based therapies they should. And the only way to do that is to set up a system to make it easier to do what we should do and to make sure that patients are getting these therapies, no matter who the care provider is. And in this stage of the project, what we're introducing is this tool called the Learning from a Defect tool. This is perhaps one of the most powerful and successful tools that teams have found in our large-scale collaboratives. And we can apply this really broad. We can apply this, how will the next patient be harmed at any event, any infection, anything that happens. But though many times our organizations, when big things happen, we have mechanisms like root cause analyses to really understand and dig into the system to understand why that patient suffered, you know, significant harm or threat to life and limb. This tool here, what we're trying to adapt this to is this project is when you find that patient who didn't get the spontaneous breathing trial, who didn't get the spontaneous awakening trial, who didn't get that subglottic suctioning endotracheal tube the way they want them to really step back and to use this tool to really try to uncover what happened. They didn't get the subglottic endotracheal tube, they didn't get their spontaneous breathing trial, they didn't get their sedation turned off, they're too heavily sedated. There are a lot of what happens. The next step is, why did that happen, right? What is it about our system? What is it about our institutional policies, our unit level policies, our task factors? Maybe it's some provider issues and a lack of awareness and knowledge. So there are all kinds of system factors, but really what is it within our ICU for this patient on this day that they didn't get the therapies they should? And the third step, as Dr. Latif outlined, is what do you think we can try to do to make that better, right? And oftentimes we focus on standardizing care, creating independent checks. Hopefully at some point, maybe Eman can take a note. We really need to talk about the daily goals form. Daily goals is essentially an adaptable checklist that can be used every day at the bedside to help ensure that patients in the ICU get the therapies they should. And then finally, that last step is, how do we know that that risk is going to be reduced? And for this project, again, if we're focusing on a head of bed and subglottic tubes and spontaneous awakening trials and breathing trials, we have measures now that we'll be able to follow that over time. So what we're trying to do is to try to build capacity within our ICUs, right? Not just like any other project where we continue to educate providers, we continue to focus on individual nurses and doctors to make sure that they're doing. Don't forget, and set up all these reminder systems and education programs. And then when those providers turn over and there are new providers in our ICU, then we have to start that education process all over again. Instead, we want to make sure that we have the protocols, we have the policies, we have the setup within our system to make sure that patients are getting these therapies that they should. And the learning from a defect is a practical tool that helps us work together. So it would be the nurses and the doctors and respiratory therapists and our CUSP team, right, that would use this tool when we find a patient who didn't get the spontaneous awakening trial they should, when they didn't get the spontaneous breathing trial, their subglottic tube, use this tool to try to understand why is that? Because it's not about the nurse at the bedside. It's not about that one doctor who's taking care of that patient, but it's really about that system, because every system is perfectly designed to achieve the results that it does. So Asad, again, thanks so much for sharing and great presentation. I just wanted to frame this out and just to reiterate some of the things that you said specifically around this project and how we hope teams are going to use this tool now to begin to really dig a little bit deeper when patients aren't getting the therapies they should, to understand what is it about our system, how we've set care up to make it, you know, that perfectly predicts whether patients are going to get the therapies they should. Eman or Dr. Arabi, any other comments?
Thank you, Dr. Berenholtz.
Thank you so much for this interesting talk. Any comments here in the crowd with me? If you have any question or comments. Thank you so much. We'll go to Mr. Abdullah Al Zahrani to start with his talk about objective outcome measures. And it's very interesting, and we have heard a lot of questions from hospitals regarding this. So I hope this will answer some of the questions, or almost all. Thank you so much.
Assalamu alaikum. Thank you, Eman. Thank you, Dr. Sean and Dr. Asad. It was a great talk, and we will always, hopefully, we will try by this measurements to learn where is the defect and hopefully improve with time. So we received many questions related to the outcome measures and objective measures. So, as you can see here from the website, I will talk about mainly the VA rates and objective outcome measures. VA because we are using the data collection tool that we are using for measuring the VAC and IVAC with VVAP to get also the outcome and objective measures. So this is the data collection tool that we are using for each patient following with time. And do you hear me now? Okay, do you hear me well or? Okay. So we are following patient by patient in this data collection tool, and I will tell you how we're gonna manage entering the data that we are getting from this data collection part. So the main thing, which is the VA rates and the components related to VAC and IVAC with the VVAP. So this is when you log into the website, this is how you get it. So you will enter the month, year, and also the ventilator days with the total number of VAC, IVAC, and VVAP. So the question is which month and year that you will enter. So to answer this, we will enter the month and year that the patient first got the first episode of ventilation. So once you have your patient ventilated, you will start collecting data based on this form. And for example, the patient might be admitted in the last month, but he got intubated into this month. So the data will be represented for this patient based on the new episode of ventilation. So, so this is why we need to select the month here. The second part, which is related to the patient ID. So the number of ventilated patients this month will be the number of the count of the patients. How many forms on how many patients you collected data for. And for number 3, which is related to total number of ventilator episodes. So this will be one of the outcome measures as well. For number 4, which is the total number of 10 days among patients initiated on mechanical ventilators this month. So we will count all the yes that you will be plotting here. So we need to follow up the patient till he's discharged from ICU, or at least not more than 90 days. For number 5, which is the total number of ICU days among this ICU. So this will be the difference between ICU admission date and ICU discharge date. So I will again explain it in the next few slides. So for the VAE, the month and year, it will be taken from this part, from here. And we'll keep following up the patient, even if he spent more than 1 month. Let's say he spent 1.5 months, we will repair the data for the first data point was plotted here. So the month in this column will be used in this field here. So this might delay your data entry. You might not get all patients who started the episode of ventilation in that month. You might not have them completed the form. So you have still time to enter them once you have all of the data ready for you. For the ventilator days, so again, you will count all of the yes from this column, and you will get them for all patients. So you have one form now, but at the end, you will have multiple forms representative for all patients within this month, and you will count or you will sum all of the ventilator days, and you will enter them here. Total VAC and IVAC with BVAC, it's straightforward. So you will get them from here, from these boxes, and you will take them again for all patients who started ventilator or getting an episode of ventilation at that month. So for VAE, it's straightforward and it's hopefully clear. We will move to the next part, which is the objective outcome measures and its components, mainly mortality, length of stay, and duration of mechanical ventilation. Again, it's monthly data entry. Okay. So this is the data that's required to be entered. So we have the month here and number of ventilated patients this month new to this ICU, total number of episodes in mechanical ventilation this month, and the total number of 10 days this month, and the total number of ICU days this month, and finally the total number of deaths in the ICU this month, which is representing the outcome. So again, if we go back to the form, the month here will be, this one here will be filled once all forms completed, and it's a daily data collection. So you'll collect the data for the VA on a daily basis, but at the end you will take all of the data and you will enter them in the website on a monthly basis. but you might have delayed data entry because of some patients might stay longer than a month. And the rule here is to follow up the patient for 90 days, or if he is discharged from the ICU. So if the patient was intubated and spent 90 days, he will be followed for that for that particular patient. But if he spent more than 90 days, then we have to stop the data collection for him. So again, we will take the month year from here, which is when we started the episode of ventilation. It's not the admission date again. And for the number of ventilated patients, it will be the count of subject IDs. How many patients you filled this form for. And for the total number of episodes on mechanical ventilation this month, it will be again taken from the boxes here. So again, it's not for one patient, it's for the whole patient's forms. So you'll take it from all of the forms, you sum them together, and you will enter them in the database. To say that any patient who got intubated, he will have one episode at least. So we expect for each form to have one episode at least. For the fourth one, which is the number of vent days this month, this will be taken by counting yes, and it will be plotted here, total number of vent days. So at the end of each form, you will count how many vent days, and it will be written here. Then you will take them, or you'll sum them all, and you will enter them to the form. And the same thing for the ICU days. So the ICU days, it's the length of stay. So the length of stay is the difference between the ICU admission to the ICU discharge, the days that the patient spent in this ICU. And for the final one, which is the number of deaths in this ICU, as you can see here, the outcome or the patient status, it's either discharged from the ICU alive, or transferred to another ICU, or died in this ICU. So if the patient died in the ICU, we will count how many deaths, and we will plot them as mentioned, monthly basis. I hope this is clear. If you have any questions, please, you can ask in the website, or Cheryl, do you have any questions? Okay, so yeah.
We have 10 minutes more, and if you have any questions or comments, please either unmute yourself and say them. And please make sure to scan and send the VEA forms by the end of the month, even though the data are not complete for the patient. Hide the MRN for protection of human rights, and send me scanned on the NASAM at NGHA email, please. Thank you so much. Dr. Asiri, I would like to invite Dr. Asiri and Dr. Zahir Asiri to close out this meeting. Thank you so much.
Great. Thank you very much, Eman, for this very nice, organizing the webinar. And I would like to thank our colleague from the state, Dr. Altaf and Sean, for their nice contribution. We learned a lot. Maybe the main thing is basically we apply what we learned today, how we can deal with errors. And mind everybody that WHO as well addressed 10 items this year for the next 5 years, and most of them are safety measures, and they're concentrating in the ICU and the emergency practice. So we are on the right track. With NASAM as well, we will have major contribution to the safety program in the whole kingdom. And as all of you know, that we have a center now in Ministry of Health about safety, patient safety. So it's basically everybody from Ministry of Health very well engaged in the program. The new update is we basically more of allocating resources now for NASAM. We allocate Bashir now. He's a clinical pharmacist to be part of NASAM team here in National Guard, and he will be a link between NASAM group and the Ministry of Health hospital. So I hope by having Bashir with the crews that we'll have more engagement of our Ministry of Health hospital. So if you have any questions, do you have any questions, Cheryl? Sean or Dr. Alto, do you have any comments, any added point that you want to share with us?
No, Sean, I'd be interested in hearing what the teams think about applying this learning from a defect to address potential gaps when patients aren't getting kind of some of these NASAM process measures that we're advocating for. What do the teams think about this learning from a defect tool? Yeah, what are their thoughts about this?
Great. Any ideas? So did you apply this tool in your center, Sean or Altaf, in the state?
Yeah, so a lot of people applied this tool. By far, this is one of the most popular tools across all of our projects. You know, there are a lot of examples in the national CUSP or MVP program where teams, you know, would apply it exactly as I described. You know, to when patients didn't get the spontaneous awakening trials they should, right? There must be a reason for that, right? Nobody walks into work. No, doctors, nurses, respiratory therapists, pharmacists, nobody walks into work and with the intention of harming a patient, right? So we all care deeply, we all try really hard, but maybe we don't have, you know, maybe there's a lack of education, maybe there's a lack of awareness about these, maybe there's a lack of agreement, right? Maybe there were some examples where teams uncovered that, you know, physicians didn't agree with the spontaneous awakening trial, or nurses were too concerned that waking somebody up, right, without sedation, that they were going to harm themselves, or they were going to get, you know, self-extubated and cause some harm. So this tool was a way that teams could better uncover what's going on within our ICU. What's that ground truth, right? When the rubber hits the road, why is it that patients aren't receiving the spontaneous awakening trials they should? And this tool provides a way to really understand what those system defects are and to help us begin to address them more systematically. So yeah, there were many, many examples. This was a really popular tool. Many teams also use this tool for like morbidity and mortality conference, right? So when we review a complication for a patient, it's easy to focus on, oh, those surgeons, or, you know, oh, those nurses, if they would just be more careful and try harder, right? This tool is a way to disarm that and to bring everybody to the table to really understand that it's not about doctors and nurses. It's about the system in the ICU and how we're set up that really determines outcomes. And we can use that in a number of different ways. I hope that answers your question.
Yeah, great. Thank you very much. Great. Any other questions or comments? Well, thank everybody. That's very nice. And we'll see you maybe next, after a month? After 2 weeks. Thank you, everybody. Great. Thanks.
Thanks,
Thank you.
everyone. Good luck. Good luck. Thanks, Dr. Latif. Good job.
Yeah, good.
Thanks, everybody. Take care.
Thank you, Dr. Latif and Dr. Sean.
Thanks, Eman and Cheryl. Thank you.
You're welcome. Thank you. Just I want to answer if Dr. Ahmed is still with us, Dr. Ahmed Qurashi. Just want to answer regarding the MRN. I meant hiding this MRN by replacing it by subject number, like hiding the number here instead of MRN, put any number like one consecutive numbers like 1, 2, 3. So So to identify the patient only, but without identifying the patient at your hospital, like identify for you to make it easier to follow the patient. That's it. I hope this answers your question. Thank you so much, and have a nice day. Thanks.
I had shared. If you want, I can.
Yes.
I can share my screen, or